Good evening. Welcome to the Myasthenia Gravis Association virtual monthly meetup. We're so glad you're here. I'm Catherine Clemens, Community Program Coordinator for the Myasthenia Gravis Association. If you're new to the Myasthenia Gravis Association, we hope you'll check out our website at www.mgakc.org for additional programs and events happening. If you're newly diagnosed, please email us at info@mgakc.org. That's info@mgakc.org to obtain a new patient packet. Following our meeting tonight, you'll receive a survey which also lists upcoming virtual programs. You'll note that we have a session on October 2nd at 5 p.m. Central Standard with Dr. Henry Kaminsky about how MG care would look in 2044. There will be a link in the email to sign up for that session. Also in the email, you'll see our 64th annual meeting and educational seminar is coming up on October 26th from 8:30 to 1 p.m., which features two exciting keynotes. Our meeting will be hybrid, so you may attend in person or virtually. If you decide to attend virtually, you will get a packet in the mail from the meeting. For tonight's presentation, we are excited to have one of our most familiar faces to us, Dr. Mazen Dimachkie of the University of Kansas City Medical Center. University of Kansas Medical Center. Dr. Dimachkie is a tenured professor of neurology and director of neuromuscular division of the University of Kansas Medical Center, KUMC. Dr. Dimachkie is ABPN board certified in neurology, clinical neurophysiology, and neuromuscular medicine, and holds a UCNS certificate in clinical neuromuscular pathology. He is Executive Vice Chairman and Chairman for Research Program, Department of Neurology. He is the Associate Director of the Institute for Neurological Discoveries at KUMC. Dr. Dimachkie has a national and international reputation as a clinician, educator, and researcher. In addition, Dr. Dimachkie is on the Medical Advisory Committee for the Myasthenia Gravis Association and an integral part of our clinic partnership at KU. We're grateful he is taking the time this evening to share with us more about CAR T therapies and MG. Please welcome Dr. Dimachkie.
Thank you, Catherine. This is a wonderful introduction. I'm going to go ahead and screen share my slides, and let me make sure this is working properly. I'm going to stop screen sharing for a second and go back and close one thing and open up another thing. And now we should be in good shape. All right, now when I do this, and I changed the laser point. Okay, so thank you first for the kind invitation for me to talk about something I'm learning a lot about. And thanks to you asking me to prepare this presentation, I've learned even more about. It's about the use of re-engineered cells in patients with myasthenia gravis. You can hear me okay, I presume. Wonderful. So my name is Mazen Dimachkie. I'm a neurologist at the University of Kansas Medical Center. We're going to focus our interest on this part of the nervous system, the junction between the nerve and the muscle called neuromuscular junction. And that's where problems occur in myasthenia gravis, which we know is an autoantibody mediated disease, meaning your immune system is recognizing something that's normally you that it shouldn't recognize as a problem and starts attacking it. And that's what myasthenia gravis is. The majority of the attack, we know, is against something called the acetylcholine receptor. There are other receptors that have been involved in attacks in myasthenia gravis by the immune system, and these include MuSK antibodies, LRP4 antibodies, and yet to be defined smaller numbers of proportions of patients have unknown antibodies. The major antibody is the acetylcholine receptor antibody, accounting for 80% of all patients with myasthenia gravis. MuSK accounts for somewhere around 7%, LRP4 2 to 3%, and then the rest then is where we have about 5% of patients with generalized myasthenia gravis that may not have an identifiable antibody. So our agenda today is to talk about how the immune system works. Because to understand CAR T therapy, we need to understand the type of cells and how they function within the immune system, particularly the immune system that has to do with antibody production, because we know myasthenia gravis is antibody mediated. There's different types of immunity, as you'll see, and the interest will be in how can we modulate or change the immunity that's mediated through antibodies. And then what about what we know about CAR T? CAR T is well known in the cancer world. There have been therapies for the last 6 years or so in cancer that have been developed with CAR T therapy. So we can learn a lot from that. And then what are the known side effects of CAR T? Because this would have implications as we consider these as therapies in myasthenia gravis, an immune disease, and then focus at the end on CAR T as it pertains specifically what's being done currently in MG. Now, having been in research and education field for quite a while, these are the companies I've consulted with or grants that I've received. And of course, my presentation will not reflect any of the biases from those uh, connections and interactions. So let's jump into the immune system. And I put here the reference of where I got this from. We can think of immunity as something that occurs rapidly within the fraction of a few minutes. When you get an exposure to a microbe, there's something that doesn't require much time to develop. In a matter of hours, you have these neutrophils, then phagocytes, and these type of cells called NK cells, natural killer cells. That's what NK stands for. And these are very helpful to defend your gut, your skin, and your oral mucosa, those membranes, from bacteria that are floating around. But then there's another part of the immune system that takes really days to react. It's called adaptive. Innate system, rapid within hours, adaptive, taking days, weeks to respond. And the adaptive immunity has to do with the cells called, these are forms of white blood cells, lymphocytes. Now, polymorphonuclear cells, phagocytes, NK cells are also white cells, but they're different. They're not lymphocytes. The lymphocytes that are part of the adaptive immune system are the B lymphocytes, we also call them B cells, and T lymphocytes, we also call them T cells. And they interact with the antigen and they produce either antibodies when it comes to the B lymphocytes. There's a myasthenia gravis antibody, right? So these are B lymphocytes that are generating the antibodies that cause myasthenia gravis, whereas the T lymphocytes are those that produce cells that are activated, that are ready to attack antigens. And the antigen typically is a bacterium or a virus, but in the case of myasthenia gravis, it's self, meaning it is the human body itself. So just going over innate immunity, this is a picture of it where it's complex. The neutrophils are the type of white cells, the monocytes, the eosinophils, the macrophages, all of these are part of these innate responses, natural killer cells. There are cytokines, which are uh, agents that will optimize, increase, amplify the immune response, and that results in inflammation. And this is different from this two-armed or two branches of the adaptive immunity, where some of it is antibody mediated and the other is cell mediated. You have the B cells are the center of the antibody mediated response, and the B cells get activated. they get exposed to an antigen and they become activated B cells. They go into the status of plasma cells. And plasma cells start secreting antibodies. And once they are done with secreting the antibodies, they become memory B cells, which means when the next time they see the same antigen, those memory B cells are ready to react a bit quicker than several weeks within a few days. Whereas the cell-mediated immunity is displayed is based on an interaction of the T cell with some kind of trigger, an infected cell displaying an antigen, and it goes into memory status down the road. So let's focus a bit on the B cells. And why to focus on the B cells? Because there's several types of them, and because we think that there's an antibody. We know there's an antibody in most patients with myasthenia gravis, and the source of antibodies we know are the plasma cells. So how do plasma cells evolve into plasma cells and plasma blasts and memory B cells and secreting cells that are activated? So this is complicated here, and I'll show you another cartoon that's a bit more simple, but not super simple because this topic is rather complex. But the whole idea is that there's something that happens in the bone marrow. You have precursor cells, and before they become B cells in the bone marrow, which is where all the red cells, white cells, and the platelets are generated from your bone marrow, you have precursor cells called pro-B cells. Then it goes from a pro-B cell to a pre-B cell. They have different surface markers. Notice this is CD20 minus. This is a surface marker called CD20. The pro-B cells don't have it, whereas the pre-B cell are plus when it comes to that. Notice that then the immature cells will be able to secrete Ig immunoglobulin, whereas this pre-B cell is not able to secrete immunoglobulin. So there are different things maturationally that happen within the bone marrow, ultimately to release in the bloodstream something called naive B cells. Naive B cell is a B cell that's not seen antigens, and it's just kind of looking around, trying to see, is there something foreign that I should react to? And if it sees it, that becomes activated B cell. And then the sequence of event becomes into development ultimately of what's called memory cells and plasmablasts that secrete different antibodies along the way, especially when it comes to those plasma cells. So now we know that there are stages in the B cells, that not all B cells are equal. There are different markers on them, and that there are some steps that may be more important for targeting because they have relevance to antibody production. So if you target these cells here, well, it might make sense, but these are not the ones that are responsible for the disease, whereas cells in this compartment that are producing antibodies are more likely to be then activated and be kind of able to target myasthenia gravis receptors, and therefore are the problem cells to be focused on in case of a targeted therapy. And that's what we're going to be talking about. We're going to talk about CD19 quite a bit. It's a surface marker that is a target of some of the CAR T therapies. We're also going to talk about B cell maturation antigen. B cell maturation antigen is abbreviated BCMA. So when we talk later on about CAR T, you'll hear me say, and this is targeted towards BCMA or this is targeted towards CD19. That's what I'm referring to. And just in case you forgot what CD19 is, it's this marker here, CD19 plus, that's decorating those different forms of B cells. But notice plasma cells become weak in CD19, but they're positive in BCMA. That's why we can target this compartment with CAR T or that compartment with CAR T when the expression of the CD19 becomes weak, but BCMA becomes stronger with those long-lived plasma cells that produce also antibodies. So it is a B cell maturation regulator. It has different agents it interacts with. This is more basic sciencey that we need to discuss, but it was initially found on normal B lymphocytes and malignant plasma cells. That's where the BCMA was discovered. But again, it's a therapeutic target currently when it comes to autoimmune disease. So now I'm going to switch gears now that we had a crash course in immunology about B cells and different markers on B cells, CD19 and BCMA, which we'll come back to. This is a cancer video. This is from MD Anderson Cancer Center, and I'm going to stop sharing and reshare something else. And it's a brief video, about 2, 3 minutes, and it's kind of old. It's from about 5 years ago, but it exemplifies, shows what is the CAR T therapy in the field of cancer, not in the field of myasthenia, but gives you an idea of the parallel of what the process looks like. So let me share the screen of this video. And I think if I go here and let me see something. If I do that and go there we go. And I'm going to put it to a full screen and start it. It's less than 2 minutes, so please bear with me. You can see the video there. Good. T cells are.
Dr. Dimachkie, I don't think we can hear the video.
Yeah, so that's going to be a problem with the video. Let me see if I can fast forward to something that is a little bit more illustrative of what I'm trying to show you. So the cells are modified in a lab, the T cells, the T lymphocytes, to attack the cancer cells. And this is an example of how it is done. You get what's a process called leukapheresis, which is removing from the blood the white cells from the patient. So this is autologous, meaning these T cells are derived from the patient themselves. And then there's a process after that where the T cells are first concentrated. And once they're concentrated, they're modified with those receptors on top of them in order to recognize the cancer cells. So you pull out the white cells, leukapheresis, they regenerate easily in the bloodstream. Out of those, you purify the T cells. From the T cells, you amplify them. Then you transfect with a viral vector the T cells with this red substance, and that red substance now recognizes the cancer cells in the case of cancer. And then what you do, you go back after this, what's called manufacturing process, then to re-infuse the patient with those CAR T cells when they're grown in large numbers and they're infused in the patient right there. So that's the kind of the concept that I was trying to, provide in the way of what CAR T process is. Now, this is shown in a video that didn't have an audio, unfortunately. I didn't anticipate that. However, as I try to show you the same in a slide, let's see here. The same concept here in a slide shows you the steps. Leukapheresis, getting the white cells from the patient by putting a catheter. Is like a dialysis machine or plasmapheresis. Some of you may have had plasma exchange. It's like plasma exchange, but what you do, instead of removing the gamma globulin portion with plasma exchange, in leukapheresis, you're removing the leuco, which is white cells. That's what leuco refers to. Then you have a manufacturing process. Those cells are sent to a central lab that does T cell enrichment. You want the substance the product to have mainly T cells. Then you take a virus to transfect the enriched T cells with that receptor that makes them capable of attacking the target, in the case of cancer cells, and then you expand them, you multiply them so that once you give them to the patient, there's a lot of them. And then you reinfuse in the patient. These are the three key steps: leukapheresis, manufacturing, and reinfusion. And in manufacturing, there are three key steps. I make it sound simple. This process of manufacturing can take 60 days to get past the leukapheresis, to get to the point where we're ready for reinfusion into the patient when it comes to, say, for example, myasthenia gravis, because we've done this in myasthenia gravis. So all sounds good. This has really revolutionized the care of leukemia and cancer. But what do we know about the and patients who have had leukemia or other bad diseases that are terminal? They would respond to this treatment. But what about the downside? What about the side effects? There are a couple of side effects that are important to keep in mind. One of them is called cytokine release syndrome. This is like within a day or two of the infusion. So this is more immediate in effect. People can get fever, confusion, leading up to even severe CRS, where there are more complication than that, blood pressure drops or things like that. So that can happen. It's the most common complication faced by CAR T patients. It's a fever, low blood pressure, high pulse rate, respiratory problems, muscle aches. Sometimes can be advanced clotting in the bloodstream and lack of clotting, a mixture of both, bleeding that is, kidney damage, and it can affect the CRS, can affect any system, can be the brain affected, can be the liver, can be any organ, and usually occur quite rapidly, and they peak around 1 to 2 weeks after infusion. And there's something that correlates with the severity of the CRS, and this is something called interleukin 6. That's what IL stands for. Interleukin 6. It's a substance that gives us the idea that to block the CRS, you give an antibody to the receptor of interleukin 6, and there's one that's commercially available called tocilizumab. And tocilizumab is one of the approved therapies to mitigate, to improve the cytokine release syndrome. Now, this is one of the reactions. The advanced reaction, typically when people get to this one, they've started with the CRS, and then they evolve into what's called ICANS. ICANS is immune effector cell-associated neurotoxicity syndrome. It's the first letter of each of those words. And this is when 3 to 10 days after the infusion, there's so much inflammation, leakage across the blood-brain barrier, inflammation. It results into confusion that can lead up to seizures and more major problems. And in severe cases, it can be fatal. And so ICANS is commonly associated with and follows CRS. So the sequence of events, a complication starts as a CRS, may stop there if it's mild, but sometimes it evolves into what's called this ICANS. So what are the risk factors? Now that I scared all of you about ICANS and about CRS, does everybody develop it? At least in cancer, we know some risk profiles, which means younger patients, at least being older is protective in this case. If you have pre-existing neurologic or medical issues, high disease burden, this is patients with cancer. If they have a larger tumor or more widespread tumor, for example, or before treatment with the CAR T, there's something called lymphodepletion, which is given a conditioning regimen with fludarabine or Cytoxan, and it causes low counts. So the deeper the intensity of the lymphodepletion therapy, the more likely patients will develop ICANS. These are not 100% guarantees, but these are things that have raised the risk. And then, of course, if the cytokine release syndrome is severe, then the likelihood of developing after that the ICANS, the brain nervous system problem, is higher. So now that I told you about these things, the ICANS can lead to confusion, some hallucinations, language dysfunction, headache, tremors, inability to write, seizures, can lead up to coma and even death secondary to brain swelling. So this is a serious thing. So patients that come in with CAR T therapy for cancer, not for MG, but for cancer at KU, we, the neurology team, will follow them on regular basis to measure their CRS score, their ICANS score, to see if they're headed towards trouble or not. And most of the time they don't, but we are vigilant, we watch for that. And how do we score them? This is the ICANN scoring sheet. It's called the ICE score. You look for the grade 1 is the lowest grade, grade 4 is a bad deal, and you measure several different things. Is there a depressed level of consciousness? Are there any seizures? Are there any motor findings? Intracranial pressure that's increased. And notice there's an ICE score orientation for naming, for commands, for writing. So we get all these together and are able to put patients in a grade. And therefore, if it's a mild grade, the response will be different as opposed to a moderate or advanced grade. And this is taken from up to date. So there are ways to monitor closely, be proactive, and treat those complications. And we know that we have some ways to treat them, especially with blocking the IL-6 receptor. Now, let's go
We
to
do have
MG.
a few questions. Do you want to wait till the end to do all
Yes,
questions? Okay.
absolutely. Um, so the now let's talk about MG. Now that I've told you all you need to know about cancer, but hopefully none of you have cancer, and but let's talk about what you have, MG. Now, there are several different programs that are using CAR T, and you notice here I put a double A CAR T in myasthenia gravis. And then you'll understand here in a minute what the difference is. This is CAR T stands for chimeric antigen receptor to the T cells. And these are different programs that are targeting the common form of antibody, the acetylcholine receptor antibody positive MG, and they have different constructs, different targets within there. And the goal ultimately of doing that is hitting the reset button for or reboot button of the immune system. You're trying to reset the antibody production back to a naive stage. Remember where I said here earlier that these cells here are naive, they don't produce antibodies? You're trying to bring back the B cells to this stage, to their youth, before they become activated by doing that. And this way, those cells don't produce antibodies against anything, including against yourself. And they start learning the new antibodies. So that's kind of the reboot process that we're trying to do with the CAR T therapy using the single A CAR T that targets the antigen. And the antigen in this case is going to be one of two things. The BCMA, and I told you what BCMA earlier was, and this is one of the markers of long-lived plasma cells, and other CD19, which is more so on the short-lived cells, plasmablasts, which also secrete antibodies. Conditioning protocol to improve the survivability of the CAR T cells. Some programs, and not all of them, will require pre-treatment with fludarabine and cytoxan. These are chemo drugs. So you knock down some of the endogenous immunity right before the infusion, and then you infuse. So there's leukapheresis, production, but before the infusion, Flu-Cy comes in, and then you infuse. Now, with CD19 targeting, we expect that CD19 will cause low gamma globulin. But one of the questions you might ask, what about I got my pneumococcal vaccine or flu vaccine? Will that knock down my immunity? There's data from lupus that indicates that the vaccine immunity is not damaged by this process, that it persists. And here, there's a research also going on in double CAR T. This is where the target, instead of it being the antigen, now is the antibody itself, because we know that in myasthenia gravis, the B cells that produce the antibodies have the antibodies on their surface. You can imagine a B cell with different spokes on the top, and all of these are the MuSK antibodies. So if you have a targeting of those antibodies with double A CAR T, then you have selectively depleted those small proportion of B cells that are activated specifically to generate the MuSK antibody and cause the disease. We overall think that the frequency and the severity of reactions in autoimmune disease, I'm talking about lupus, scleroderma, rheumatoid arthritis, myasthenia gravis, myositis, these are the autoimmune disease where CAR T is being tested. We think that the likelihood of getting those CRS and those ICANS are much lesser. And we think this has to do with the fact that we don't have a large tumor that we're faced with, but rather an immune system that we're managing. So going back to a simplistic cartoon, and I promised you that earlier on that I'm showing you a more simplistic cartoon. This is one way to look at it. Remember, those plasma cells are targeted. I have this marker called BCMA. So whenever you give a CAR T that's targeting BCMA, is targeting those plasma cells that secrete IgG. The IgG is the antibody that's knocking down the acetylcholine receptor. Whereas if you target CD19, and notice here, this box in red has BCMA, but CD19 and CD20, this is CD19 right here. You see it highlighting those cells. CD19 will target all of these cells, whereas BCMA will focus on these plasma cells, to some extent on the plasmablasts. So there are different strategies of doing this, but the idea is either you knock down this CD19 or this BCMA. With the CAR T, you target those. And when you target them, then you go back to a naive phenotype, and the B cells, therefore, are no longer producing antibodies. Notice what happened here. This is nice. This is the bone marrow. This is the bloodstream. This is the immature B cell. When it gets to be mature B cell, it starts producing the IgM antibody and the IgD. Now, we know in myasthenia gravis that the antibodies are IgG. These are the memory cells. These are the ones that we want to tackle because they're producing IgG antibodies, whereas those have not yet produced IgG antibodies. So what happens when you knock down with the CAR T those white cells, they come back to a phenotype that has the IgM and IgD. They're naive, but they're not yet in the memory pool where they're producing antibodies. So it's a whole reset of the immune system. That's the promise of the CAR T therapy when it comes to myasthenia gravis. So now we talked about the theory of it. Well, what's going on right now? This is the studies that have shown some improvement in non-cancer patients using CAR T therapy. I'm not going to talk to you about lupus, not talk to you about systemic sclerosis, which is similar to scleroderma, not going to talk about myositis or lupus with myositis or multiple sclerosis, but there are studies that have shown that CAR T can work for those diseases. I want to focus on this, myasthenia gravis, because that's what we're talking about here tonight. So this is what we know. These are the two studies that have shown that patients do relatively well when you treat them. Now, I talked to you earlier about BCMA and CD19. Guess what? Descartes, which is Descartes 08, that's one of the studies. It uses BCMA. That's what it targets. Kyverna study, KIV 101. This one is using specifically CD19. So these are the two targets right now for CAR T. And these two studies, these are the doses, And these are the side effects: no CRS, no ICANS, no CRS, no ICANS. Clinical improvement was noted. Rapid improvement was noted using BCMA or CD19, patients are getting better, and these are early stage studies showing efficacy. So you're wondering now, these are results that came out. Well, are there studies ongoing? Is that the end of the story? Well, a lot of studies are ongoing. These are the studies that are non-cancer CAR T studies that are ongoing. This is not an old review. This is from June of this year. But believe you me, this is not a complete list. And it tells you about how much of an interest already there is in CAR T. However, when it comes to MG, because we're talking about MG tonight, it highlights the fact that Kyverna has a phase 2 study. That's the next phase study, again, targeting CD19. The T cell source is autologous, meaning from yourself, as opposed to something that's off the shelf from a donor. So there's a manufacturing process that takes time in between. So now finally, okay, that's fine and dandy. And I already told you that's not all the studies that are going on. What else is going on? What's going on at KU? Can I do a study at KU, for example, that involves CAR T? Can I show an interest and explore it? Well, guess what? You can. So this is a study that's being led by Dr. Pasnor as the site PI. It's not a one-site study. It's a national study by Cartesian. Dr. Pasnor is one of the participating sites at KU. She's leading that study. And this is for patients who are acetylcholine receptor positive generalized myasthenia gravis, but even seronegative patients are included. And we're looking for people to participate in this study. Another study that we have available that I am leading is looking at myasthenia gravis. And this is the profile of the study overall. Now, to close and to make it a bit more complex and make it a bit more interesting, there's something called BITE. And these are the BI stands for bispecific, and T stands for T cell, and E is called engager. And this is the concept in cancer whereby you have CD3 antibody, you take a piece of it and you combine it with the target antigen that you want to work with, make the composite here based on the T cells, and then if it is a target cell, here in the case of myasthenia gravis, it would be the B cell. In the case of cancer, it's a tumor cell, then you can destroy it. And for autoimmune disease, the target is not a tumor cell, but more so a B cell. Again, the targets being on the B cell CD19 or BCMA. And you wonder, well, why is he telling me about this? It turns out in cancer, there are two drugs on the market, teclistamab, which is targeting BCMA, and blinatumomab, which targets CD19, with similar efficacy to CAR T. But what's interesting is that there are case reports of using these same drugs in dermatomyositis, in rheumatoid, in lupus, in sclerosis, and showing that patients get better. It resets their immunity back to that IgM, IgD naive profile and depletes the IgG that way. So this is an example of what these T cell engagers are, the BiTEs, teclistamab and blenremimab. This is FDA approved for multiple myeloma back in 2022, 2 years ago. In 2018, blenremimab was approved to target CD19 for forms of leukemia that are B cell leukemias. But there also, this drug was shown to be promising in a study of rheumatoid arthritis. I'm not going to go into that study, but I want to show you a study of teclistamab that included, when I think of myasthenia gravis as a neuromuscular disease, there are similar diseases that are also antibody mediated, one of which is myositis. So when it comes to teclistamab itself, a BiTE, a bispecific T cell engager, there's this case reports of 4 patients, one of whom had dermatomyositis with an MDA positive antibody I can walk you through all this slide, but what I'm trying to say is this drug helped this patient skin disease, muscle disease resolve by treating this patient with this drug called teclistamab, and it's a BCMA targeted T cell engager. So at this time, you may have a million questions. So this is time for me to listen to your questions, try my best to answer them. Thank you for paying attention.
All right, I'll go ahead and start reading through them. For which neurological autoimmune disease have we had successful CAR T cell clinical trials? Um, Asking stiff person syndrome, if that is one of them. I know you had that document, but are there any additional?
So these are the studies that have shown success so far. I don't see stiff person on the list there. Let me look at the next list. Let's see if we missed stiff person syndrome hiding somewhere that's currently being tested. And I don't see it represented here. But it's a great idea. There's an antibody in stiff person syndrome. Why not?
Yeah. What type of patient is best to receive CAR T cell therapy? Any particular characteristics that include or exclude patients?
So I would not want to ask a patient to be part of a CAR T study if they've not been through some of the standard MG treatments. And nowadays, we have so many therapies available in MG, and we can get most people with MG in good remission for a long period of time. So I don't want this to be thought of as, well, I have MG, I'm newly diagnosed, I want to do CAR T. No, I think it's best to go through the standard therapies first. And if things work out, which they do most of the time, but it takes time, it takes a year or two to control MG in the first period of it, then that's perfect. They worked out. Those therapies helped. But in someone who's struggling, still, despite trying one therapy, two therapies, or more, maybe it's time to think we want to do research. And research, there's so many options. We have, we've talked about CAR T therapy research studies at KU. I didn't tell you all the CAR T studies we have in the works. We have 5 CAR T studies actually between active and in the works. So, but there are other studies in MG that are not CAR T based and are very promising. So research becomes the question after failing 2 drugs with myasthenia gravis. And in research, then you have to decide which is your cup of tea, depending on how frequent the visits are, what's the risks associated with it. So I don't know that there's one profile of patient that tells me this is the right patient for a CAR T only study. It's more so of an individual choice after reviewing the risks and benefits. For some patients, the symptoms of MG are so bothersome that the risk associated with CAR T and the potential benefit of a moonshot type of cure for years to come from MG and being off treatment is worth it. This is kind of a conversation you have with your doctor. This is a conversation you have with the researcher that's talking to you about the research studies available so that you can make an educated choice. So one of the things we do at KU, if you're interested in research studies in MG, we have to offer you all the studies available, which can be confusing because we have quite a few of them. But at the same time, it educates you, it enlightens you so that it's not us making the decision for you about which study. It's a conversation, a dialogue about what your questions, what keeps you up at night about your myasthenia gravis, what is it kind of the best for you to give you, arm you with information so that you can make the best educated decision.
And I know it for at least for MG, it's only in trial, it's not FDA approved yet. But with your experience, are there any conditions, health conditions separate from MG that you would advise a patient not to participate or not even participate because they probably wouldn't qualify, but once it was FDA approved, are there any conditions that you would not suggest a patient to do so?
Yeah, I mean, generally speaking, patients that get into those studies are of general good health, for
Mhm.
example. Um, They don't have a lot of comorbidities associated with them. They don't have severe illnesses that can complicate the treatment. There are, overall doing well in other areas besides MG being a big problem for them, you know. So I would think that this is where the risk benefit kind of comes in the way of, well, we're going to take that risk, but how big a risk? Is it a kind of big leap, or is it just a moderate sized risk that would be reasonable? And everybody will have different levels of risk tolerance. Again, none of these are prescriptive. Again, this comes back to this educated, dual decision making between the physician and the patient. And I have to say, this is really early days. I mean, we are really at the forefront of doing, CAR T and the beginning of doing CAR T in immune diseases. This experience in MG is just a few years old, and it's really important to step in with caution and not really, um, you know, generalize that, oh yeah, this is safe, go ahead and do it, there's no problem, everybody does well, everybody gets better. We thought that's why I put in the side effects. That's why I put in the ICANS, the CRS, because even though they're supposed to be less, we know they will happen. And that's why it's a good way to look at, yes, I may gain something, but what could I risk losing?
Which is a perfect lead into our next question because it's about side effects. Is there any good data on CAR T side effect probabilities?
Yeah. I mean, this is what I brought earlier in the way of that slide. That's why I wanted to wait till the end to have those questions because I knew they will pertain to some of the slides that I presented. So thank you for this question first. And this is at least what we know from the cancer literature. And you can see the slide here that says, we know that in cancer, for me to say this is true for myasthenia gravis would be incorrect because we don't know, but we extrapolate. What we think still might be an issue is if you do like pre-treatment beforehand with fludarabine and cytoxin to improve the longevity of the cells. That's why we treat them. You want the CAR T cells to persist longer. But then if you do that, then the risk of the ICANS CRS is higher. We don't have this issue of malignancy burden. There's no tumor there in myasthenia gravis. Remember, I said let's say someone has seizures already, and you put them on this, and they have myasthenia gravis too, but seizures, right? Well, how do we grade the ICANS? One of the grading system is now they have seizures, focal generalized, non-convulsive EEG. That's really kind of makes you think, well, is that the right person to get into this study or get the therapy? And then if they have this CRS, but this is after the fact. CRS is you get the infusion, then you get the fever and the confusion to some extent, but it involves into the severe ICANS. And we think that high levels of IL-6 are part of it, but that's also after the fact. So bottom line is lymphodepletion, comorbidities. I don't know if younger age applies here to myasthenia gravis patients or not. We don't know. But clearly, medical comorbidities, lymphodepletion, we know that these are going to be more risky towards CRS and ICANS. And I predict these will carry through in immunological neuromuscular diseases, including myasthenia gravis.
Related to age, is there a age that it is not advised to, at least to participate in the MG trials? Is there an age limit for the trial currently?
Some studies do have age limits on them. I think that it depends. Each study is different, but I can leave a contact number for anybody who is interested to learn about, or an email address. Let me get the email for Ali here. It'll take me a quick second, and I'll put it here in the chat. This way, if you have specific question about an age cutoff for one study or another, we can let you know. Um, but I suspect there is an age cutoff, and I'm gonna get those ready for us here as I'm doing this. I'm gonna give you two contact information. I know Andrew Heim is in charge of one of our studies, and Ali Rousseau is in charge of the other study. I'm gonna copy those. Let's go back to the Zoom. If I stop sharing for now and put them here in the chat box, and you can see those two contact information there. Please reach out if you have questions or specific to age of qualification.
All right, next question. Is there any connection with the COUR uh, nanoparticle delivery method for infusion?
I don't have a comment or insight into that. Actually, I have to say, we had a stem cell and CAR T therapy conference at KU this past weekend, and a lot of topics were kind of discussed, but not the nanoparticle delivery method for that. But that sounds interesting, the concept.
All right, I have another one, and it's a long one with lots of acronyms, so I apologize if I stumble. I read all BCMA CAR T case reports for NMOSD from IASO Bio and their other reports in MG mitosis, as well as BCMA reports in MM, and notice CD19 plus goes to, or positive goes to 0 in all cases when used without anti-CD19 CAR T. Why do you think this happens? If CD19 positive B cells and PB are not PCMA positive, and do you think this points to BCMA alone could be enough for a reset?
That's what I think is happening. I think this is a very good and insightful question as to how now we think we understand how this works. And this is what the question is about. Thank you for paying attention to the presentation. So I was saying all along that BCMA is present on those two populations of cells, but when you give the BCMA CAR T targeted, you're not only knocking down this, but you're knocking down reprogramming, resetting the whole system. And that's usually what happens. You induce a deep reset of the whole system, and those cells here are affected. So very good question. I think it tells us something that while we think we understand a lot about the immune system, we don't understand it fully. And yeah, so I mean, there are reasons to favor one mechanism to say, well, CD19, this is good and fine and dandy, but we know BCMA is very important because these are the plasma cells, the professional antibody producing plasma cells. And guess what? In myasthenia gravis, it's an antibody mediated disease. It's the antibody that's the problem. Very good.
Yeah, and our last question that I have on here is related to that as well, asking if one seems more effective than the other, which I
I don't
think
know.
you, yeah.
Yeah, I mean they're both exciting. There's no head-to-head comparison. Let's be upfront about it. They're still early days. They're being tested. There's no study that's comparing one to the other, but some studies are testing CD19, others BCMA, and we're just waiting and seeing as to we want something approved for myasthenia gravis. We want the next thing approved. Then we can do perhaps retrospective comparative studies and maybe prospective comparative studies. Right now, we cannot tell.
And we just had another question come in. To what extent does, is it leukapheresis stage clear out the B cells producing the MG antibodies?
So the purpose of the leukapheresis is not to clear them out. It's more so to capture some of them because the bone marrow keeps on producing them at a rapid rate. As soon as you clear them out, the bone marrow is pumping some more from the bone marrow to the bloodstream to replace them. So you can see where this is a temporary process. Remember, also we're not pumping out the B cells from lymph nodes or tissues, the neuromuscular junction area where B cells might be, or the lymph nodes, or the thymus for that matter. There's some B cells in the thymus. We're just taking them from the bloodstream. So the rest then diffuses back into the bloodstream as soon as you take them out. So the purpose of the leukapheresis is not so much so to deplete the B cells, but to capture those T cells that are really part of that soup and then enrich them, purify them, decorate them with the right target to become CAR T cells, and then amplify them before they're infused.
Yeah, and this attendee also said that they were part of the Descrates '08 trial and received the leukapheresis, but was in the placebo group. And they still have, or they're still in remission for almost a year, or have been for almost a year.
Maybe leukapheresis does something good. Who knows?
Yeah. No.
That's why we do placebo-controlled studies because we always wonder about what the intervention is doing as opposed to part of it. Yes, a great
Mhm.
question.
Yeah. And we do just have a few more minutes, so if you have any other questions, please send them in and we will um, try to get it answered. Otherwise, thank you so much for your time, participants. Some awesome questions. But we'll hang here for a few minutes in case there's any other questions coming in.
The way I'm impressed with the level of questions that people are asking and the interest in this technology. Clearly not for everyone, for sure, but hopefully it'll be established to be safe in myasthenia gravis, that down the road we can say we have one more treatment that's a major advance in myasthenia gravis, a game changer, hopefully.
Mhm. How
Wonderful.
long do you think we are from having a deployable therapy?
I don't have the inside track on this. I think that some of the programs that are most advanced are with the Descartes '08 program. I don't know how soon or how close they are to getting to the point where they feel comfortable with the FDA filing to look at potential regulatory approval. That's usually the steps. You ask for a meeting once you have your data locked and your analysis done, and you show that you have a positive effect. And you have to do better than leukapheresis, right? That's one of the conditions. Leukapheresis alone is not gonna, so it's gonna take some time. And the honest truth is, I don't know. And if I had an inside track, I probably shouldn't share it, but I don't have an inside track either.
And then I have a comment for you. Really appreciate the presentation. It was very understandable.
Yeah.
Uh, I know that the discussion is about MSG. I was just, or I just want to share something that I am experiencing. I have systematic, uh,
Sclerosis,
something derma, ceruloderma.
scleroderma.
For 4 years now, and I'm about to start CAR T trial with Dr. Boyan at Cedars. Is there any advice or helpful information that you could share? And thank you.
Yes, I could tell you, check with your doctor who you're doing the research study on, as far as the information that I presented to you and shared with you. These are some of the areas of interest where there's been, some promise of reduction of antibody, reduction in fibroblast activation. This is systemic sclerosis, the cousin of what you're talking about. This is a reduction of antibodies, also reduction in activation, prolonged persistence of CAR T, improvement in skin fibrosis and lung function that's been described in these early phase studies. And currently, what's being done in systemic sclerosis, there are some studies that are scattered through here that are being done in systemic sclerosis. So um, I think this is where you have to have a discussion with your doctor. You see systemic sclerosis listed here as one of the study. This is in China. That's a study that's going on. There are others, I'm sure, that are listed here, like systemic scleroderma, right there, CAR T with this other company. There are many companies that are coming through the woodwork, and you just have to probably sit down with systemic sclerosis right there again. This is by Juno Therapeutics. And so, there are a lot of those studies. I'm glad you have access to a place where you can explore that question. I encourage you to discuss that some more with your doctor. I don't have additional import to that question.
Oh, thank you. And thank you so much for your time. We are out of time tonight. So again, thank you so much for attending. If you have any further questions, you can email us at info@mgakc.org, or make sure you copy those emails that Dr. Dimachkie posted in there. So thank you and have a great night, guys.